Hi, good morning. My name is Rondi. I'm a second year medical student from Southwest University. What is your name?
I'm Krisha.
And what's your age?
I'm 28 years old.
Hi, Krisha. I'm going to be doing a neuromusculoskeletal examination today. Is that okay with you?
Yes, it's okay.
Alright. The first test I'm going to do is the olfactory nerve. And I'm going to be using this, asking the patient to identify the scent on each nostril. Could you close your eyes for me? Okay, go ahead and block one of your nostrils. I'm going to ask you to identify what the scent is.
Menthol.
Go ahead and do the other side as well.
Menthol.
Okay, so the next test I'm going to perform is CN2, or the optical nerve. And I'm going to be using the smell chart here, holding it about 6 feet away. So let me back up a little bit. I want you to look at the smallest text that you can read. Go ahead and block one of your eyes. There you go. And go ahead and read the smallest line that you can.
L-P-F-E-H.
Good. Go ahead and cover your next time.
L-P-F-E-H.
It seems that the patient can read the last line here, which shows that she has 20/20 vision with both eyes, as long as she has eyeglasses. The next test we're going to perform is we're going to be testing CN2 and CN3, CN3 being oculomotor. I'm going to be shining the pen light in her eyes to see pupillary reaction, if they react to the light and constrict. As I shine it on both sides. Go ahead and take off your glasses for me. Stare past me. I'm going to be examining. We've already dimmed the lights. That's really loud. Her pupil constriction appears normal. The next exam I'm going to perform is CN3, CN4, and CN6. It's going to be 6 cardinal fields, direction gaze. We're going to check for nystagmus, also lateral movement, up and down movement, side to side, as well as diagonal movement. Superior and inferior rectus for up and down movement, lateral and medial rectus for side to side movement, superior and inferior oblique for outward and upward movement. I'm going to ask you to follow the tip of this pen here. I'm just going to move this. Just go ahead and follow. Do not move your head. Very good. Thank you. Her movements appear normal in both eyes. The next nerve we're going to test is CN5, which is a trigeminal nerve. We're going to test both motor and sensory or corneal reflex. First, we're going to check the motor nerve, looking at the masseter and temporal muscles, checking to see if she's able to move. Go ahead and shoot. Right, there we go. Again. Muscles are working there. Go ahead and push down. There you go with your jaw. Alright. Thank you very much. So it appears that her motor nerves are doing fine. Next, I'm going to be using this cotton ball. I've already extended it to touch the cornea for a corneal reflex and check and see if both eyelids blink at the same time as I touch her cornea. Stare back here. The next I'm going to be checking for is CN7, or the facial nerve. I'm checking the facial muscles, frontalis, as well as the lower muscles, palpating as I check for facial expressions. And raise your eyebrow. Go ahead and frown. Go ahead and smile. Good. Go ahead and puff your cheeks for me. Puff your cheeks. Puff your cheeks. There we go. Very much. Appears that her facial nerve muscles are doing fine. The next nerve I'm going to be checking is CN8, or vestibulocochlear nerve. I'm going to be asking the patient to repeat words that I've said as I cover one side of the ear or the other. One, two, three. 5, 6.
4, 5, 6. 3, 4, 5. 3, 4, 5. 2, 0, 1.
She can hear whispers on both sides of her ear. The next nerves I'm going to be testing is CN9 and 10. CN9 being the glossopharyngeal nerve and CN10 being the vagus nerve. CN9 for sensory, CN10 for motor. I'm going to be using a tongue depressor, touching the posterior wall of the pharynx on both sides to check for gag reflex. Go ahead and open your mouth. Say Let's touch. On. Next side. Okay. Thank you. Her gag reflex is in working order. The next nerve I'm going to be checking is second to the last CN11 accessory nerve, which innervates the trapezius and sternocleidomastoid muscles. So I'm going to ask you to lift. Go ahead and lift your shoulders up like this. So if you're sharpening, go ahead. Good. One more time. Right. That checks for muscle strength. Lastly, I'm going to check CN12, the hypoglossal nerve, evaluating the patient's tongue movement. Go ahead and open your mouth for me and stick your tongue out, then move it from side to side. Thank you very much. The next phase is for the motor system. We're going to first test for muscle strength, both upper and lower. The first we're going to perform is the grip test. It's going to be dermatome C7, C8, and T1. Go ahead and give me your right hand. Pull and go ahead and grip and pull back. Oh, very good. Next arm. Good. Good grip strength. The next test is the test for the opposition of the thumb. It's going to be dermatome C8, T1 as well, and the median nerve. Take your right hand, push down, try to touch your pinky. Okay, very good strength. Again, try to touch. A little weaker, but still pretty strong. Go ahead. Thank you. The next I'm going to test is for the ankle dorsiflexion as well as plantar flexion. With dorsiflexion, I will be testing mainly L4 and L5 and the tibialis anterior. For plantar flexion, checking mainly dermatomes S1, gastrocnemius, and soleus. Feet up so I can go ahead and push against upwards towards downwards as well. Plantar flexion. Dorsiflexion. And plantar flexion. There's plenty of strength there. Thank you very much. The next movement test, we're going to check for the cerebellum and the gait. The cerebellum coordinates movements such as posture, balance, or coordination, as well as speech, enabling it to be much more smoother and balanced. The first test I'm going to perform here is the finger to nose test. Go ahead and put your finger to your nose. And then go ahead and touch my hand. Touch again. You're going to check for ease of movement, if there's any tremors, and coordination as well. Go ahead and use the other hand. Alright, thank you very much. Looks like she's very coordinated and her control is there. The next test I'm going to perform is the heel to shin test. Go ahead and put your heel right underneath here, opposite knee. You're going to run it all the way down to here to a triangle big toe. Go ahead and do that for me. Back up. Okay. Go ahead and close your eyes now and try it again. You're going to be checking for accuracy and the coordination of movements. Good. Go ahead and do the other side as well. Control. Next, close your eyes. Right. Very good. Alright, the next test is going to be the rapid alternating movement of the arms. Go ahead and do all of this. You're going to be touching back and forward like this as quickly as you can. One arm. Go ahead and do the right arm first. Okay, pretty good. Go ahead and do the next arm. I'm going to be checking for speed, rhythm, and smoothness of her muscles. It appears that also the non-dominant hand may perform less than the more dominant hand. Next is going to be the walk heel to toe or tandem walking. I'm going to have her follow this line, toe to heel. Go ahead and follow the line. Alright. Next is going to be the Romberg test. I'm going to have the patient stand. and she's going to be with feet together, eyes open, and then have her close her eyes for about 30 seconds and just observe her as she is standing. I'm going to be noting the patient's ability to maintain her stance in an upright position, and to see if there will be any drift. Go ahead and stand, feet together. Go ahead and close your eyes. And do this for 30 seconds. Next, we're going to check for pronator drift. Go ahead and hold your hands up and forward. You're going to hold it there for 30 seconds. Go ahead and close your eyes. Moved, which is good. I'm going to be testing for pain using this pen here. I'm going to specifically be looking at dermatome C6. Go ahead and draw arms forward and facing upward. Go ahead and close your eyes for me. Is this sharp or blunt?
Sharp.
Blunt or sharp?
No.
Blunt or sharp?
Sharp.
Blunt or sharp?
Sharp.
Blunt or sharp?
Blunt.
Okay. Do so with the other side of your arm as well. Is this blunt or sharp?
Blunt.
Is this blunt or sharp?
Blunt.
Is this blunt or sharp?
Sharp.
Is this sharp? Blunt?
Sharp. Blunt. Sharp.
Okay, very good. Thank you. I'm going to be also testing for temperature along the C6. Go ahead and open your arms. Okay. Close your eyes for me. That. Hold.
Cool. Cool.
This one. This one.
Cool.
Okay. After which, I'm also going to be demonstrating along C6 also light touch. Go ahead and close your eyes for me again.
Yes.
This. This.
Yes.
This.
Yes.
Thank you. Now I'm going to check for stereognosis. Go ahead and close your eyes for me. And I'm going to ask you to identify the object that I'm going to place in your hand. So go ahead and hold your hand up. What is this?
Pen.
What is this?
Ink.
Go ahead and hold your hand. What is this?
Key.
Then hold your right hand. What is this?
Key.
What is that?
Pen.
Last thing.
Tape.
Okay. Thank you very much. Next, I'm also going to be performing anesthesia. Go ahead and close your eyes for me and hold your palm up. I'm going to be writing a number, and I hope she's able to identify it.
1. 3.
Okay, go ahead. Alright, thank you very much. Next, I'm going to do the 2-point discrimination using this device I made, which has 2 points on her finger pads, to check and see if she can identify either 1 or 2 points when I touch your finger pads. Close your eyes.
2. 1. 2. 1. 1. 2. 2. 2. 2.
Thank you very much. Lastly, we're going to check for point localization. So I'm going to ask the patient to close her eyes. I'm going to touch a spot on her arms. Go ahead and open your eyes and point to where I touched. Ready? Okay. Close your eyes again. Good. One more time. Good. Thank you. So it's reflex time with the reflex hammer here. First, we're going to be doing triceps and biceps. Biceps being C5, C6 dermatomes, and triceps C6, C7. And checking the biceps reflex, I'm going to be placing my thumb close to the biceps tendon right here, just above the antecubital fossa. And I'm going to put some pressure on it, and then I'm going to tap it with the reflex hammer. There we go. And the next one. Relax, relax. There we go. Thank you. Next is the triceps reflex, so go ahead. Put this arm up. Relax, relax. Locating the tricep tendon here. So I'm going to be striking the tendon with a direct blow just above the elbow. There we go. Next one. Relax your arm. Okay, thank you. The next is the patellar reflex. Just below the knee, there's the patellar tendon there, and also you're going to be checking the quadriceps L2, L3, and L4, watching for the extension of the knee. You can locate it by palpating. There's a little notch right here where you can strike the patellar tendon. So I have my patient sitting for the ankle reflex. We're going to be looking at the Achilles or ankle reflex, which is S1 primarily. We're going to be striking with the flat part of the reflex hammer, striking just behind where the Achilles tendon is, asking the patient for a slight dorsiflexion, and then the striking. Action there. Okay. Last, we're going to check the plantar reflex, which is about L5 to S1. I'm going to be using the bottom end of the reflex hammer as well, going upwards, stroking from the lateral aspect of the sole all the way to the ball of the foot, curving medially across it. I'm going to be using the lightest stimulus needed to provoke a response, closely observing for the movement of the big toe, normally plantar flexion. Alright, here we go. For our patient, Krizia, 28, appears to have appropriate cranial nerve response, specifically in her sensory nerves, as well as motor reflexes. She was able to identify scent. Her gaze was consistent. There was expected facial movements, and corneal reflex was fine. And also her tongue movement and gag reflex was also present. Her muscle strength was adequate, both for grip and opposition of thumb, as well as her ankle, plantar and dorsal flexion. Her gait was fine, as well as finger to nose test, heel to shin, and movements on her arms and walking. And it appears as though there was no drift. In her sensory, tests for pain, temperature, light touch were appropriate, definite proprioception, as well as being able to identify numbers in stereognosis, as well as graphesthesia and 2-point discrimination and point localization. And all her reflexes appeared normal.